SAGES Principles for a Safe Cholecystectomy, Expert Strategies to Prevent Bile Duct Injury. Welcome to today's podcast episode, where we explore the essential techniques and strategies promoted by the Society of American Gastrointestinal and Endoscopic Surgeons for performing a safe cholecystectomy. Our focus is on creating a culture of safety in the operating room, aiming to prevent the most serious complication of this procedure, bile duct injury. Establishing the critical view of safety as the gold standard, let us begin with the foundation of safe cholecystectomy, the critical view of safety. This technique is the gold standard for correctly identifying both the cystic duct and the cystic artery before dividing any structures. To achieve this view, surgeons must clear the hepatocystic triangle of all fat and fibrous tissue, separate the lower third of the gallbladder from the liver to expose the cystic plate, and ensure that only two structures, the cystic duct and cystic artery, are seen entering the gallbladder. This careful approach dramatically reduces the risk of mistaking the common bile duct for the cystic duct too. Recognizing and responding to anatomical challenges. Unexpected anatomical variations and inflammation are common hurdles in cholecystectomy. It is crucial for surgeons to recognize when the anatomy does not match expectations. When faced with uncertainty or considerable bleeding, the recommended approach is to pause the procedure, openly address concerns, and seek assistance from colleagues or more experienced surgeons. Utilizing alternative techniques, such as subtotal cholecystectomy or other bailout procedures, can be life-saving. In addition, intraoperative imaging methods, such as cholangiography or near-infrared fluorescent cholangiography, provide valuable assistance in mapping the biliary tree and clarifying anatomy when needed. 3. Using intraoperative imaging techniques wisely. Intraoperative cholangiography involves injecting contrast material into the biliary system and taking X-ray imaging to outline the anatomy. This technique is particularly useful when the identification of anatomy is unclear, when variants are suspected, or when there is concern about stones in the common bile duct. Another innovative method is near-infrared fluorescent cholangiography, which uses contrast agents and specialized cameras to visualize the biliary structures in real time. These imaging techniques serve as important adjuncts to the critical view of safety, providing a detailed roadmap of the ducts before any division is made. 4. Understanding risk factors for bile duct injury. Awareness of specific risk factors is essential for preventing bile duct injury. Some conditions significantly increase the risk, including acute cholecystitis lasting longer than 72 to 96 hours, severe chronic inflammation, Merizi syndrome, portal hypertension, cirrhosis, and unusual anatomical patterns such as a very short cystic duct. By identifying these high-risk scenarios before or during surgery, surgeons can adjust their operative plans, seek help early, or opt for alternative approaches such as partial cholecystectomy. 5. Knowing when to seek assistance and employ bailout techniques. Calling for help is a demonstration of wisdom and a commitment to patient safety. The operating room culture should encourage pausing for a second opinion when needed. Bailout strategies, such as subtotal cholecystectomy, where the gallbladder is opened, stones are removed, and the posterior wall is left attached to the liver, offer safe options when the critical view of safety cannot be achieved. In particularly challenging cases, it may be safest to stop the procedure, place a drain to control bile leakage, and refer the patient to a hepatobiliary specialist or plan for a later intervention. 6. Promoting a universal culture of safety. Finally, the most important strategy is fostering a universal culture of safety within the operating room. This involves team training, encouraging every member of the surgical team, from nurses to anesthesiologists and assistants, to voice concerns. Cognitive aids, such as checklists and posters displaying the critical view of safety criteria and decision algorithms, can serve as valuable reminders. Above all, the environment should be non-punitive. Viewing pauses, requests for help, or conversions to an open procedure as indicators of exemplary patient care rather than shortcomings. In summary, by integrating these 6 strategies, surgeons and institutions can significantly reduce the risk of bile duct injury in cholecystectomy. Thank you for tuning into this episode, where safety and excellence in patient care remain at the forefront of surgical practice. If you enjoy the content, please like, share and subscribe. It's the Everything Surgery Podcast. Dissect the extraordinary.